I'm going to talk about passion. For many of you who know, I feel passionate about what I do. I have no disclosures, however, to reveal. And it's been an incredible honor and privilege to have served as president of this organization for the last year. It's a tremendous organization that works on the behalf of patients suffering from GI disease, as well as the practitioners of those of us who operate on the GI tract. The task of the president, the work that goes on within the organization, that was really shepherded by the administration, and I have to thank John Blackstone, Heather Nutter, and the rest who really do all the heavy lifting. But the leadership standpoint of the organization is really done by the chair of the board, who's the immediate past president. So Selwyn Vickers, who's sitting here, has been an outstanding and mentor over the last year. And Sel, thanks so much for what you've done. So over the last few years, there's been much concern about the increasing incidence of the burnout syndrome among surgeons. So I'm going to try to address this issue by sharing the story of what kind of drew me into GI surgery, highlight the dynamic nature of what it is we do, and make a plea to those of us in the profession to kind of wrestle ourselves and our colleagues out of the quagmire of burnout by nurturing our passion for what we do. As mentioned in Dr. Barron's kind introduction, I performed my general surgery residency at the University of Utah. Entering the residency, I had no clue of what branch of surgery I was interested. The department at that time was chaired by Dr. Frank G. Moody, again, a past president of this organization. I'll talk more about him tomorrow morning when introducing the Moody lectureship. He was ardent in his enthusiasm about GI surgery and surrounded himself by a cadre of junior faculty who felt the same way. Their passion for what they did was truly palpable, especially for somebody just out of medical school. I had no intention of becoming an academic surgeon, but midway through my second year of residency, it became clear there was a numbers mismatch, and one of us would have to stay behind a year to do research. Since my wife and I had a 2-year-old son at home at the time, it made sense to take the year off to have more family time, as well as to moonlight for some extra cash, and to ski in the beautiful Wasatch Mountains that you see here behind the picture of University of Utah back in the day. So I volunteered to step out of the clinical residency and do a year of research, and so I looked around to all the faculty in the institution to see who had a research project going on that would be interesting, and I decided to throw my lot in with Dr. Bing Rickers, an expert in liver disease and portal hypertension, and another past president of this organization. I spent a very interesting year, however, doing investigations of liver blood flow and reticuloendothelial cell function, and caught the bug to be an academician. Now, Bing tried to get me interested in portal hypertension. There was no way that was going to happen. But what I did do is I then went on to the Mayo Clinic and accepted a slot as an NIH-funded research fellow in the digestive disease unit there under the tutelage of Dr. Keith A. Kelly, yet another past president of this organization. It was an incredible 2 years spent investigating GI motility and peptide hormones, and while there I also overlapped and worked with Mike Sarr, who you can see on the far right here, another past president of the SSAT. It was a very productive 2-year period, and I accompanied Drs. Kelly and Sarr actually to the 1987 SSAT meeting here in Chicago, and I've not missed a DDW meeting since then. What strikes me, though, looking back at all these mentors, that they were all absolutely passionate about academic GI surgery. Without their influence, my career would undoubtedly have taken a profoundly different pathway. I was then hired at WashU in St. Louis to perform basic science research and maximally invasive surgery. Although I was enthusiastic about this new chapter in my career, at that time, GI and general surgery seemed to be in the doldrums at that time. There was little excitement in the field, and it was a shrinking cosmos, with interventional radiology and GI, among others, encroaching on many operations that had previously been done by surgeons, but using less invasive techniques. 3 decades later, I would submit to you that GI surgery is an incredibly dynamic field with many new advances, an explosion of GI-centric postgraduate fellowships, and a field that makes up more than 50% of the operations that the average general surgeon does. However, though, there's also a flip side. Increasing bureaucratic oversight and regulations, RVU-based compensation, and major issues accommodating to the electronic health record have all decreased satisfaction among practitioners, with a well-documented increase in this so-called burnout and a high attrition rate among surgical residents. Earlier this year, I sent out an email survey to past presidents of the SSAT and other leaders in GI surgery. I have to say, this was a totally unscientific survey, and no statisticians have been asked to analyze the data, but it did receive a 90% response rate. The first question I asked was to list the most impactful advances in GI surgery during the respondent's career. There were many answers related to specific niche areas, but the responses could be distilled down into 5 major buckets. In reverse order of response frequency, GI surgeons felt that advancements in imaging and interventional radiology had had a major impact on what we do. These thought leaders also felt that the development of quality metrics and systematic QI efforts have led to significant improvements in patient outcomes following surgery of the alimentary tract. A third area that was highlighted was the explosion of subspecialty fellowships in GI surgery and the increasing subspecialization within our field. Another often repeated response was the increased importance of flexible endoscopy and the blurring of boundaries between what have traditionally been GI medicine and surgery over the last few years. However, overwhelmingly, the most cited advance in our field over the past several decades was that of laparoscopy and minimally invasive surgery, the so-called laparoscopic revolution. Laparoscopic cholecystectomy, first performed 3 decades ago now, if you can believe that, heralded a new era of approaches to abdominal pathology performed using minimal access techniques. The evolution and adoption of MIS procedures had led to virtually any operation previously performed by laparotomy to now be approached by smaller and smaller incisions, limiting the postoperative pain and disability. The adoption rate of various operations has been variable, with more than 90% of cholecystectomies now performed laparoscopically, whereas segmental colectomy is performed only around 40% of the time currently in the United States. Even very complex resectional and reconstructive operations, such as the Whipple operation, are now being done routinely using MIS approaches in many institutions. I have to admit I'm a little bit embarrassed for having gone on record in the mid-1990s as saying that the laparoscopic Whipple operation was a triumph of technology over common sense. Much has evolved since the first laparoscopic cholecystectomy. Advances have been made in the laparoscopic technology, moving from single-chip camera vision displayed on tube televisions to high-definition images displayed on flat screens. Equipment initially stacked on mobile carts now is suspended from elegant booms. Rudimentary clip appliers have been supplemented by articulating staplers. Monopolar electrocautery has been augmented by many devices that coagulate blood vessels and divide tissue effortlessly. In the 1980s, general surgeons occasionally requested new forceps and retractors from the OR supply chain manager. Now we ask for incredibly expensive and technologically advanced instrumentation. Training techniques have also evolved, from hands-on training in the OR to simulated models and validated educational and evaluation programs such as the Fundamentals of Laparoscopic Surgery program, now mandated by the American Board of Surgery for all general surgery residents. Robotic technology has also been developed to improve imaging, instrument tip deflection and range of motion, and surgeon ergonomics. Unfortunately, given the monopoly on this field and the cost, I have gone on record as saying at the current time, sometimes this doesn't make sense for many of the things that we do. Surgeons have pushed efforts to further minimize the deleterious effects of abdominal incisions by decreasing the size and/or number of them, or even eliminating them entirely by using natural orifice transluminal endoscopic surgery. Of course, the holy grail for the MIS surgeon is to deliver therapy in a totally non-invasive manner. These advances, as well as many others, have a major impact on what we now consider the norm. The evolution in the science and practice of GI surgery demonstrates the wide range of areas that have developed in a relatively short period of time, each of which can be used as a platform for meaningful clinical interest and investigation. So now, continuing on with my personal story, when I arrived at Washington University, there was a huge political fight as to whom would own gallstone lithotripsy at Barnes Hospital. And many of you may not remember, there was a brief window in time where it was thought if kidney stones could be fragmented and taken care of, well, why not gallstones? And a number of places went bankrupt chasing this, but we weren't too different at Barnes. There was a huge political fight as to who would control lithotripsy. And so how it was solved was 2 lithotripsy machines were purchased, one to be controlled by the interventional radiologist and one controlled by a combined effort of GI medicine and surgery. So for those of you who don't know, this is a spark plug that was used in one of our ESWL machines. And it's one of those historical things that most people have no clue what it was. But we had a gallstone center at WashU, which again was unusual for a tertiary care hospital to care at all about gallstones. And I would go out and lecture regionally about this gallstone center, where we could either treat people with lithotripsy or by mini laparotomy cholecystectomy. And again, for those of you who remember, we were trying to take out gallbladders through incisions this big, which I think was the least safe operation ever done. But that's what we were doing. And I would lecture about this, and after one of these evening rubber chicken dinners at a community hospital, a local nurse asked, had I ever seen this publication? It was the original publication in Laser Practice Report regarding the first 2 laparoscopic laser cholecystectomies that were reported by Dr. Eddie Joe Reddick, a private practice surgeon in Nashville, Tennessee at Westside Hospital. Well, I didn't subscribe to that journal then, nor do I now, and I hadn't seen it, but when I read it, it made sense because this laparoscopic procedure could actually remove the offending organ and get rid of it with little incisions and minimal morbidity. Now, at that time at WashU, one of our urologists, Dr. Ralph Clayman, shown here on the left, it was kind of one of those crazy first-generation endourologists, and he had been advocating for there to be a general surgery partner for him to join in initiating an applied research program in abdominal laparoscopy. And he was able to get some old-fashioned GYN equipment from industry, his contacts at Karl Storz. We then appropriated several of the pigs that I had ordered on a different research protocol, modified various rudimentary laparoscopic hand instruments, and were able to perform laparoscopic cholecystectomies on several unsuspecting pigs. For those of you young people, these are diazo slides, cost $3 each to make, white on navy blue. This was an exciting time, and I remember thinking that we might be able to publish 3 or 4 papers about this new type of surgical intervention. I then worked with gynecologists at WashU to actually learn how to place laparoscopic ports in humans that I thought was probably important before going down to Westside Hospital and observing 3 laparoscopic laser cholecystectomies performed by Drs. Reddick and Doug Olson, again at Westside Hospital. And actually observing these operations convinced me that the future of gallbladder removal had arrived. And in fact, this was the invoice I received a couple of weeks later for my fellowship in the laparoscopic laser cholecystectomy. So we subsequently convinced Barnes Hospital to purchase a video laparoscopic tower and the then current generation equipment for this, but we couldn't move it on site until it had been displayed at the American College of Surgeons meeting exhibit hall during the 1989 Clinical Congress in Atlanta. Reflecting the prevailing notions at that time, there was a long line of surgeons trying to see the one video of a laparoscopic laser cholecystectomy at one of the booths. with at least 2/3, if not 3/4 of those surgeons turning away in disgust and or disbelief, and the other third or a quarter clamoring to try and buy the equipment and get in on this game as quickly as possible. 2 weeks then after the college meeting, we actually got our equipment and performed our first lap chole on a very brave patient willing to be our first subject. Meanwhile, our team continued to work in the laboratory at night and on weekends and to develop new techniques and instrumentation. To give an idea of the rapid pace of development, 6 months later, we performed the world's first laparoscopic nephrectomy. There was initial resistance by mainstream surgical organizations and journals to publicize or publish MIS accomplished, but it seemed that at every surgical meeting, someone would herald the performance of a new laparoscopic operation. Well, needless to say, for a very junior assistant professor, the next couple of years were extremely exciting. Abandoned was basic science research. Instead, my free time was spent in the animal laboratory and working with industry to develop new techniques and enabling technologies. And as a side note, I would say that I would bring videotapes home to edit of lap choles because we'd be teaching a lot. And these guys would, my 2 sons are here in the front, and they would look over my shoulder, and I'll never forget Chris saying, "Ugh, gallbladder." So the acceptance, though, of lap chole among the lay public occurred rapidly, spurring surgeons to seek training in the novel method as quickly as possible. There was a tremendous need to quickly develop training curricula and hands-on courses, which led to a group of us early adopters to travel around the US and indeed around the world, teaching surgeons how to perform laparoscopic surgery. And the rest is truly history. The Laparoscopic Revolution took my career in a totally unexpected path, led to invitations for national and international collaborations, introduced me to many individuals who have remained close friends to the current time, and allowed me to pursue educational, research, and leadership opportunities that would not have otherwise been presented. What is truly amazing to me is at least 90% of what I do today, both clinically and academically, was learned only after formal training in surgical residency and fellowship. I tell you all of this for only one reason. I was extremely fortunate to have discovered a passion that I've been able to nurture throughout my entire career. The root for the word passion is passio, which is Latin for to suffer. Merriam-Webster lists multiple meanings of this word. Passion may refer to a strong emotion as distinguished from reason, an intense drive or overmastering feeling or conviction, and also a strong liking or desire for or devotion to some activity, object, or concept. Surgery is a bizarre profession in that surgeons physically assault patients when they are unable to protect themselves with the aim to make them better. Only a small percentage of physicians ever choose a career as a surgeon, and I believe that this is because surgery chooses us and not the reverse. But when we accepted that assignation, we decided to pursue surgery because we simply wouldn't be happy doing anything else. I feel confident that no one in this audience today went into surgery for the money. Charles Schwab once stated, "The man who does not work for the love of work but only for money is not likely to make much money nor find much fun in life." E.M. Forrester stated, "One person with passion is better than 40 people merely interested." And T.S. Eliot said, "It's obvious that we can no more explain passion to a person who has never experienced it than we can explain light to the blind." Surgeons who are passionate about our profession are also ambitious. They want to be able to influence the field that they love. They read about it, dissect it, and cannot escape from it. When truly passionate about something, an individual can withstand the struggles and hardships along the way. Undoubtedly, that's how the older surgeons in the audience were able to make it through that pre-80 hours work week residency paradigm and live to tell about it. Passion is also one of the ingredients of a recently described attribute known as grit. Grit, in turn, is defined as the perseverance and passion for long-term goals. This character trait is predictive of success in many stressful, high-achieving fields, and the absence of grit is a risk factor for attrition among surgical residents. As mentioned earlier, I believe the polar opposite to being passionate and exhibiting grit is the increasingly recognized state of dissatisfaction and burnout among surgeons and surgical trainees. This term was first used in a 1974 article entitled Staff Burnout by psychologist Herbert Freudenberger. The three primary components of burnout are depersonalization, emotional exhaustion, and reduced personal accomplishment. Depersonalization can be represented by the time we are harnessed to the electronic medical record rather than interacting directly with patients. Emotional exhaustion is exemplified by the time and energy expended on meaningless administrative writings, things, or writing justifications for indicated procedures that have been denied by insurance companies. A sense of reduced personal accomplishment may result from being on the hamster wheel of RVU-based compensation at the expense of truly meaningful educational or academic activities. Recent surveys suggest that the incidence of burnout has been increasing over the past few decades and is now present in about half of all general surgeons. Burnout is seen in all chronological phases of medicine, from medical students to residents to practicing physicians and surgeons. The syndrome of burnout is a function of both the person and the environment. We clinical and administrative leaders then must strive to tip the environment favorably towards the surgeon by measures that reduce the impediments to efficient patient care and minimize tiresome tasks while rewarding non-reimbursed academic and educational activities. We've got to do that for the sake of our profession. For those of us who work with surgical trainees, it's critically important not to portray to them only the negative aspects of our profession. If in your daily work you frequently complain and model characteristics of anger, frustration, and burnout, medical students and your surgery residents will not grasp the unbelievable fulfilling things that we surgeons embrace. Share your passion with those around you at all opportunities. As Dale Carnegie said, enthusiasm is contagious, and so is the lack of it. More than 1/5 of general surgery residents will leave their surgical programs to pursue other fields. Many of those who remain in residency move forward with sheer perseverance rather than with a passion for what they're experiencing. Even with reduced work hours, remember that surgical training is hard. In order to generate and maintain passion among medical students and surgical residents, we need role models. These role models must not only teach surgical procedures and principles and technique, but show that we are capable of working within effective teams. We need to demonstrate the life of the surgeon who is passionate about and demonstrates joy in what he or she does on a daily basis. We also need to relate to our trainees that the actual duty hours of practicing surgeons is significantly less than 80 hours per week, and that there is life outside of the hospital. As Eva Singletary stated, surgery continues to be a fascinating field, and students will be willing to endure the difficult training if they know that the payback will be worth it. Even with the challenges facing us, we know that it is worth it. Are we conveying that, or are we simply teaching technical skills? If the trainees are to have a passion for surgery embedded to carry forth into their careers, it must come from us. We can't teach them to have passion, but we can show it to them every day in the work we do, in our relationships with patients and other caregivers, and in the way we live our lives. Certainly, if all we model is frustration, anger, and other traits of burnout, we will winnow down the number of bright young individuals willing to come into the surgical field and disadvantage our profession in the future. It therefore seems to me that grit and passion should be antidotes to burnout. Now, I show a photo of John Cameron here, another past president of the organization. He states repeatedly, if you love what you do, you never work a day in your life. Surgery is a profession, but also a team sport and an art. Although the classical surgical personality, and you know the type, one that's overbearing, hierarchical, and frequently treats subordinates in an abusive manner, was initially expected and subsequently accepted in the operating room, it has more recently become clear that the best surgical outcomes are associated with good teamwork and a flattening of the hierarchy within a surgical team. There is a unique choreography to the interaction between the surgeon, his or her assistants, and scrub nurse that can seem magical to the neophyte. One of the unique aspects of surgery is the necessity to intervene physically by performing a procedure to achieve a desired end result. When engrossed in a procedure with all the parts of the team working in synchrony, the surgeon may achieve flow, a state of concentration or complete absorption with the activity at hand and situation. Now, I'm not going to try to pronounce this guy's name, and Jeff Matthews, who worked at the University of Chicago, where he was the chair of psychology, he didn't know how to pronounce it either. But this guy described he studied happiness and creativity. He believes that humans are happiest when they are in a state of flow, so involved in an activity that nothing else seems to matter. In the lay press, this is also known as being in the groove or in the zone. Flow is an optimal state of intrinsic motivation where one is fully immersed in the task at hand and when time seems to stand still. The ability to achieve this state of flow is dependent on the optimal mix of task complexity and the skill of the performer, and is most often demonstrated by the autotelic personality, someone who performs an act because they are intrinsically rewarded rather than to achieve external goals. This trait is also possessed by individuals who can learn to enjoy situations that most other people would find miserable. Traits associated with this personality include humility, persistence, and curiosity. These descriptions sound like those of the passionate surgeon. Now, to get back to my interactions with surgical leaders, the other thing that I asked them when I sent out this email was as follows. What are the primary sources of passion in your life? The 5 most common answers are as follows. Passion for family and hobbies and other things outside of the hospital. Social support, be it life partner, family, or close friends, is really important. Having strong support systems in place has been shown to be inversely related to attrition among general surgery residents. Developing this outside of the profession is critical to allow an individual to have life balance, not work-life balance, life balance, and to keep one grounded and fulfilled. These outside interests should ideally be developed prior to retirement. It's important to convey the nature of these outside activities and relationships to your trainees. The second thing that these leaders suggested were sources of passion was the profession of surgery itself. Some notable quotations from these email responses are as follows. Being a surgeon is a great gift that surpasses all the pleasure and hobbies I've accumulated over the years. Nothing is as satisfying as a successful operation that makes a patient feel better and live better. Surgery for me is not a job, it defines who I am. Another comment, surgeons have the best job in the world, and unlike other medical professions or other professionals where people are looking forward to retire at age 60 or 65, many surgeons, including me, continue to be passionate about what we do. It's a great life. In addition, they pay us for it. Third thing was passion for education and mentorship, or training the next generation. Again, selected comments from our leaders. We need to really tell our younger colleagues that surgery is fun. I want to inspire the next generation to be better than my generation. And the last quote is, "This is my legacy." The fourth thing was passion for improving surgical care and enhancing patient outcomes. And a comment was, "I have proof that the care I'm giving to my patients today is significantly better than ever previously." And the fifth thing that surgeons said they were passionate about was developing friendships and collaborations through academic societies. A quote from this is, "The pleasures of the camaraderie of academic surgery and the relationships I have developed over the years has been most rewarding and has given great pleasure to my life." Clearly, there are many areas of GI surgery that evoke passion among practitioners. It's critically important to search for and find one's passion within our vocation. This makes the daily toil and external hassles to be all worthwhile. This passion can be channeled to various aspects of what we do. First, a specific area of interest, anatomy, disease process, or physiology within the alimentary tract, something that you think is just really cool. Second would be the surgical profession in general, including professional associations such as the SSAT. It should be noted that the SSAT currently is undertaking major initiatives to improve the field of GI surgery. These include reaching out to members of other international GI surgery associations to enhance our global reach and to develop relationships with GI surgeons around the world. The SSAT is increasing educational opportunities for our members and others by adding hands-on courses at the annual meeting and by developing a standalone winter meeting. The first such course was held last December in Miami and received rave reviews. Dr. Stanley, the president-elect of SSAT, is organizing a course next winter focusing on emergency GI surgery in association with the American Association for Surgery of Trauma and the SAGES group. The SSAT has also increased the number of research grants for trainees and junior faculty, including career development awards for clinical outcomes and education research and research into healthcare disparities. We have partnered with the American College of Surgeons to offer a scholarship in health policy and management and have increased the number of traveling grants. These grants allow our members to visit other institutions, both nationally and internationally, to enhance their surgical practice, but also support surgeons from other countries to attend our meeting and spend time at an American institution. Finally, the SSAT, along with several sister organizations and under the leadership of Matt Hutter and Aurora Pryor, is coordinating the development of a curriculum for advanced GI surgery as envisioned by Dr. Fabrizio Michelasi in his presidential address 2 years ago. And finally, the third area that I would highlight that we need to do when we channel our passions is to educate the next generation. Without a conduit of bright trainees entering the field of GI surgery, we'll not be able to continue the marked advancements that we've seen in our profession over the last few years. Given the many administrative functions dealt them, surgical leaders often wear multiple hats on any given day. I've often been asked which one of the various roles is most important to me. Surgical chair, chief of service, board member, fundraiser, educator, researcher, clinical surgeon, etc., etc. If I had to give up all hats but one, it would be the bouffant cap worn while doing an operation with a trainee actually manipulating the instruments under my guidance. We truly have fun in the OR. One of the most satisfying notes I've received from a previous trainee reads as such: "You gave me skills, opportunity, and most importantly, you made academic surgery a lot of fun. Your passion is contagious." So my personal journey has been very fortunate, and there are many individuals who have been instrumental in whatever success I've achieved. I've been blessed to be mentored by a large number of individuals, many but not all of whom I've mentioned previously. I found my passion early on and have been able to follow it over all the ensuing years. These pursuits have resulted in membership in academic societies and participation in professional meetings, leading to travel opportunities and networking relationships with other U.S. and international surgeons. You've seen a couple of these slides that Kevin stole from me. During this journey, many close friendships have been forged with individuals who have enriched my life greatly. I've been very fortunate to be associated with two great institutions, WashU and now Northwestern University, with outstanding partners in GI surgery and medicine, some of who are in the audience today, strong clinical, educational, and research faculty, and robust administrative support. And Victoria Elliott, my personal assistant of many years now, is here in the audience. I've also worked with many bright young trainees who have allowed me to share with them my passion for minimally invasive GI surgery, and my patients have been willing to entrust me to care for them, sometimes using non-traditional and novel techniques. Over the past few years, I've tried to achieve more life balance, and Cindy sitting in the front row would say, "What life balance?" Well, I'm trying to do more, honey. These include travel, fitness, and more recently, after my knees went out, golf. These pursuits have definitely supplemented the fun factor in my existence. Finally, I have to recognize the critical role my family has played in my life and career. My parents laid the foundation and instilled the belief I could do whatever I chose. Our 3 sons, shown here in a dated photo, but Nick is the oldest in front, Rob to the right, and Chris in the back, little Chris in the back, have been great pleasures in life and have kept me grounded. Here's a little bit later. We now have 2 beautiful daughters-in-law and now 2 wonderful grandchildren, Noxie and Frankie. Last but certainly not least, none of this would have been possible without Cindy, my life partner of 39 years. We were dressed up our first date going to homecoming dance in high school. You can see why I wanted to date this beautiful woman. She's a life partner of now going on 39 years who sacrificed many of her own pursuits for the benefit of our family, who has been the lioness protecting her pride, enabling each of us to actively pursue our individual passions. In conclusion, then, these are my takeaway messages that hopefully you'll remember. Number 1, find, pursue, and cultivate your passions within surgery. You never know where it will lead you. Number 2, demonstrate this passion to students, trainees, and mentees. Let them catch it from you. Number 3, go for flow in your interventions. This is what makes surgery cool. And for me, when I'm in the operating room in my cocoon where nobody can touch me, this is the best. Number 4, give back to pay forward. Be involved in surgical societies such as the SSAT that support the profession. Donate to the foundation tonight. Help what we do. Number 5, assure some measure of life balance, not work-life balance, but life balance within and outside of the hospital. And last but not least, have fun, and may you never work another day in your life. It's been a great privilege being president this year, and I thank you very much for your attention.